I am Dr. Kimberley Doucette, and I'm a hematology oncologist at MedStar Georgetown University Hospital, and I treat patients with plasma cell disorders. The type of patients we generally see at MedStar Georgetown include a variety of patients. So I'll see some patients who have come in through the emergency room, or they've seen their primary care doctors and are referred to us to the myeloma clinic. I also see a variety of patients from the general DMV area. So I work with a lot of outside oncologists, and we have a lot of collaborative care, which I think is really helpful for patients. And so a lot of second opinions, a lot of just talking through treatments and how we can work as a team. My philosophy of care is to treat patients with a lot of dignity and compassion. I want them to feel very aware of what the treatment options are, and so that they're emboldened when they go through their journey and they know what the treatment options are going to look like. I like to spend a lot of time teaching patients about what their disease is, what the treatment's going to look like, what their journey is going to look like. I think that really helps them moving forward, and it helps us work together as a team. My philosophy of care is to include the entire team in their care, especially with a disease like multiple myeloma where patients are living a really long time. It's important for them to have all the resources because they're going to need a lot of support from social workers, from the nurses, from everybody in the team. And so I really want to create a sort of team environment, and the patients are a big part of that. I think there's a lot of reason for optimism, and the future in hematology oncology is really exciting. So we have a lot of new therapies at the forefront of research, especially in multiple myeloma. And so we've got a lot of recent approvals that are being moved closer and closer to the frontline setting. And so patients are having all these great treatment options and are living a long time. So it's an exciting time, one, to be a researcher, and it's an exciting time for patients to take advantage of all these newer treatment options. I think patients should come to MedStar Georgetown because we have a lot to offer in terms of treatment. We also have a lot of clinical trial options for patients who are looking to participate in clinical trials. And we have clinical trials anywhere from newly diagnosed to also patients who have relapse refractory disease. We also have a lot of multidisciplinary care. So we work closely with social workers, we work closely with pathologists. We have a lot of genomic and more genetic information coming through for myeloma, and that we're incorporating in treatment options. And so I think it's going to provide a lot of benefit for patients, not only to understand their disease a little bit more, but how can we tailor the treatment options to their specific disease. What's rewarding about the work I do is what we can offer our patients and giving them a lot of hope. So when patients come to see us in clinic, either they've just gotten the diagnosis or they're worried about the diagnosis. And so for me, it's important to alleviate a lot of their fears and tell them it's going to be okay. There's a lot of treatment options in multiple myeloma, and we can get them living a really long, productive life. And so that's what I love about my job and what we do. I specialize in plasma cell disorders, and that includes everything from monoclonal gammopathy of undetermined significance, also known as MGUS, to multiple myeloma, which is a cancer of the plasma cells. I also treat AL amyloidosis, which is a type of disease we see following MGUS. And then I also see Waldenström's macroglobulinemia, which is a type of lymphoma that rarely can arise from MGUS as well. Multiple myeloma is a cancer of the plasma cells, so it typically arises in the bone marrow. Think of the bone marrow as a factory of all our different immune cells, red blood cells, and platelets. So something happens to these plasma cells in the bone marrow, and they become cancerous and start growing. And so multiple myeloma can lead to a variety of symptoms. The main symptoms we look for are high calcium levels, kidney or renal dysfunction, bone pains or new bone fractures. And finally, patients can come in with a lot of anemia. So these are all symptoms from the plasma cell cancer itself, and also the abnormal antibody that the plasma cells make and secrete into the blood. So there's a lot of new treatment options and a lot of available treatment options in multiple myeloma. We generally break it down into patients who are newly diagnosed or were just diagnosed with multiple myeloma, and then in those whose disease comes back or is refractory to treatment in the future. So starting with newly diagnosed multiple myeloma, patients are generally treated with about 3 to 4 drugs up front, and they typically get about 3 to 4 months of chemotherapy or these drugs. So the 3 to 4 drugs are targeted agents, so they're not the traditional chemotherapy we used 20, 30 years ago. They're very targeted to the myeloma and as a result have a lot fewer side effects than what we typically think of in traditional chemotherapy. And so patients often even continue to work and do really well and may feel a little tired, but for the most part, they feel really good on these therapies. So after we do about 3 to 4 months of this therapy with these drugs, we either send patients to autologous stem cell transplant or they continue on this form of therapy until the disease recurs in the future. Autologous stem cell transplant is used in the majority of patients after the 3 to 4 months of therapy. And as we think of it as a high-dose chemotherapy followed by stem cell rescue. And so we work very closely with our transplant colleagues who help the patients through this part of their journey. And generally, almost all patients are eligible for autologous stem cell transplant. The criteria we truly have are patients who are fit, we think can tolerate the drugs, and are generally younger than 80, though we do sometimes make exceptions. And after autologous stem cell transplant, then you look at some sort of maintenance therapy until the disease comes back in the future. So generally, it's usually about 1 drug, sometimes 2 drugs in the maintenance setting. In the relapse refractory patients, so after the disease has come back in the future, we have a lot of treatment options. So it's a variety of different combinations of these newer drugs. And generally, patients will go through multiple lines of chemotherapy until we get to some newer treatment options. So we have immunotherapies, we have cellular therapies, including CAR T, bispecifics. The exciting thing about multiple myeloma now is that a lot of these newer therapies are being moved into the frontline settings. So after they initially get their treatment with their first relapse, we're starting to include a lot of these therapies. And so it truly is an exciting time in multiple myeloma, and patients are doing very well on these therapies. So the average age is about 69, though we know the range generally is from 65 to 74. So that's generally when patients are diagnosed. However, we do have a lot of 40-year-olds, 50-year-olds, up to 80s and 90s. And so it's a disease that affects a lot of people, but most common in patients late 60s, early 70s. The goal of our treatments are so that patients can live a completely normal life. So we want to get them into remission and we want them going back to work, playing with their grandkids, doing everything that they normally do. And so that's a huge goal from the very beginning of treating myeloma. And I would say the majority of patients even work throughout their initial therapy. And so patients feel good, and that's what we want. MGUS, we think of it as a precancerous condition. It's called monoclonal gammopathy of undetermined significance. The way I like to explain it to my patients is think of it as how we do colonoscopies to screen for polyps, because polyps can turn into colon cancer. This is very similar with MGUS. So it's a precancerous condition that can transform to multiple myeloma. Usually what happens with MGUS is you have some event, something that happens in the bone marrow, and some of the plasma cells become a little bit abnormal. Then they start making abnormal antibodies or proteins that we can measure in the blood. Typically, patients don't have any symptoms from MGUS, so they won't even know they have it until an astute primary care doctor or somebody looks for it and finds it. It is very common, and not everybody who has MGUS transforms into multiple myeloma. It's about a 1% risk per year that somebody with MGUS can transform to multiple myeloma. And so that is why we follow patients really closely. We look for all the symptoms, we measure blood, we measure the proteins to look for any changes that might signal a progression. To evaluate MGUS, usually we do blood tests, we do urine tests. Sometimes if the risk is a little bit higher, meaning they have higher antibodies or protein levels or a certain type of antibody that may predispose to higher risks of multiple myeloma, I may recommend a bone marrow biopsy and or imaging to see if we make sure we have no findings of multiple myeloma. But generally for most patients, it's just blood tests and urine tests, and we just watch it with time. MedStar Georgetown offers a lot of clinical trials in multiple myeloma, but also in the other various conditions we talked about. So we have clinical trials in newly diagnosed multiple myeloma, including new immunomodulatory agents. We also have trials in relapse refractory settings. So after patients have failed prior lines of therapy, we have options in that setting, including newer cellular and bispecific therapies. We also have clinical trials for Waldenstrom's lymphomas, and we also have a clinical trial in AL amyloid, those with advanced cardiac disease. And so we offer a wide variety of clinical trials to the majority of our patients who come through the front door. At MedStar Georgetown, we have various clinical trials, and we really want to make that a priority at Georgetown just because we want to treat all our patients with either clinical trials or standard of care options. I've worked in various clinical trials so far, so we have a few that are looking at cellular or bispecific therapies. We have some clinical trials in MGUS as well, patients who do have neuropathy from MGUS. We also have trials in upfront myeloma, including newer immunomodulatory agents. We also have options in relapse refractory multiple myeloma. And so there's a variety of clinical trials that we offer. With multiple myeloma, to create a treatment plan, it's really important for us to look at the whole person. And so this is the concept of precision medicine, which we really take to heart here at Georgetown. And so when we initially diagnose multiple myeloma, when we do bone marrow biopsies, we send off special genetic tests so that we have a better understanding of what's causing the disease and what genomic features underpin the actual multiple myeloma from the patient. Once we get that information, then we're able to tailor a treatment plan. Additionally, I always want to look at patient-related factors. So I want to see how fit the patient is, what their priorities are. A lot of times we don't think enough about the social circumstance of the patient, and that matters a lot when you're picking a treatment plan. And so we really, truly do want to look at the whole person and have precision medicine play a big role in how we pick our treatments. The team that we have at MedStar Georgetown in multiple myeloma is a great team. I love each and every one of them. The team consists of a nurse practitioner. We have 2 physicians in the myeloma group. We have a dedicated clinical nurse, social workers, all the administrative staff, and then 2 very excellent medical assistants. So everybody plays a huge role in the patient's journey from when they enter the door to when they get their treatments in the infusion center. And so we like to work as a collaborative team because it really does help improve outcomes for patients, and we want patients to feel safe throughout their entire treatment journey.